one of the vortex vein ampullae may be dilated with the subsequent dilatation of the large choroidal vessels. So in CSC, acute CSC, what happens is the intervortex vein anastomosis, and there is a remodeling across the watershed zone. This causes a geographic delay of choriocapillaris filling in a geographic distribution, depending on how much of the choriocapillaris is occluded. And if it becomes a chronic CSC, chronic ischemia causes neovascularization and polyps at that site. So why we should know pachychoroid is because it is a spectrum ranging from pachychoroid pigment epitheliopathy. This is the normal orientation of the pachy vessels with the vortex vein, and here you have an asymmetric dilatation with this kind of crossing of the watershed zone and intervortex vein anastomosis, causing an occlusion of the choriocapillaris first in a geographic area, and later the geographic area is kind of obliterated. Chronic ischemia because of occlusion causes neovascularization at that site, either in the form of pachychoroid neovasculopathy and subsequently polypoidal choroidal vasculopathy. If this anastomosis is in the peripapillary area, it gives rise to the peripapillary pachychoroid syndrome. And if there are choroidal polyps that collapse, or if there is some choroidal scarring, especially prechoroidally, it causes a focal choroidal excavation. All these are included in pachychoroid spectrum. So it is important to know that the morphology of the pachychoroid or the choroid is more important than the metrics, because the measurement can be increased. Like it can be more than 350-400 microns depending on the machine that we use, but the pachychoroid can be focal, which gives rise to the pathology at that site. So like we can see here, there is an enlargement of the Haller's layers causing an attenuation of the choriocapillaris. Now let's look at focal choroidal excavation. So this is a case that we had of acute on chronic CSC, recurrent CSC attacks every year for this patient. And if we see the foveal line scan, there is what looks like a typical acute CSC. But this patient on autofluorescence showed an area of hyperautofluorescence in the superior macula, and the leak was also in that site. So basically this was a focal choroidal excavation in the superior macula. This can be conforming or non-conforming depending on the lining of the excavation with the retinal and the retinal layers rather. And the FCE is the nidus usually of all problems of pachychoroid, whether it's the source of leaks in CSC, whether it's the site of MNV, and whether it is polyps. So this is another case of a gentleman of 6'6" and N6 vision who came with difficulty in reading and a scotoma. So when we do wide field optos imaging, there is a yellowish lesion in the superiotemporal macula with a lot of subretinal fluid. The fovea was flat in the horizontal line scan. However, there was Shrem in the superiotemporal macula, and when we imaged further superiorly, there was this focal choroidal excavation that was causing all the problems. Now, he was treated with 2 injections, after which he was well for a while, but he came back with a recurrence, a solid recurrence with cystoid spaces at the macula, which suggested an MNV. You can see this MNV here possibly, and there was a component of CSC as well. You can see the neurosensory dip over here. So this is the area of the CSC leaks as well as the polyps that appear on the ICG at around the 4th minute. So why we should know FCE is because it's a potential site of recurrent leakage in recurrent CSC, MNV, PCV. It is a potential area of treatment, especially if it's extramacular, and it can be post-inflammation acquired FCE where neovascular complications may arise and need anti-VEGF treatment along with anti-inflammatory treatment. Choroidal cavern, what is known is that it was first described in geographic atrophy. These are angular, hyporeflective. They can be seen in bestrophinopathy and pachychoroid. So this is a cavern which is polygonal, completely hyporeflective inside. This is one of my cases. This was a case of pachychoroid neovasculopathy, and these correspond to areas of no flow on ICGA. This was the neovascular membrane on the OCTA, and this is the area of no flow when we do Nocta through the cavern. So we should know about cavern to differentiate them from large choroidal vessels. Choroidal rifts are polygonal hyporeflective without hyperreflective margins, and the size is always more than the largest choroidal vessels. It develops perpendicular to the RPE and has filiform vertical processes. These are basically interruptions between the major vessels in the choroidal stroma. So there is a strain because of stretching, because of the fullness of the choroid or the congestion of the choroid, and these develop rifts in between the large choroidal vessels like we can see here. A choroidal loculation was described first by Spade. It is a loculation of fluid in the posterior choroid between the sclera and the posterior choroid, and it can even cause an elevation of the choroid, as was described by Manayat et al. So if we look at uveal effusion, it is a congestion of the choroid ciliary body, and the fluid freely pools in the suprachoroidal space because the attachments between the choroid and sclera are loose. But in CSC, the macular choroid is what is congested. There is only so much that the choroid can stand. So what happens when it is exceeded its capacity is that it goes further back and causes a loculation, and the angularity is directed towards the posterior choroid because of it is bound by the large choroidal vessels. So a rift, so why we should know rifts and loculation is because rifts represent areas of weakness between the large choroidal vessels and probably suggest chronicity, and loculation represents an overloaded choroidal stroma, I'm sorry for the typo, and that can no longer swell. And Spade has made this probable hypothesis that maybe we can make a shunt device at the macula which can drain out this posterior loculation. So choriocapillaris island is a CCI. It's a hyporeflective dark choroidal. It's a hyperreflective flow in the choriocapillaris in a background of hyporeflective dark area, and there is the flow area within no flow region is what an island is. It is because of a focal effacement of the choriocapillaris. I'm not sure if it is that or it is a reduced distance from the retina and hence captured in segmentation like so. And islands have been localized to leaks. A reduction in island size is seen post-treatment or after regression of the fluid. We should know choriocapillaris islands because it is used as a non-invasive tool for detection of leakage points, and it can be a potential tool for guiding focal laser. Prechoroidal cleft, I think Dr. Mohit is going to speak more about this. It can be associated with all types of MNV. It can be associated with PCV as well. This is a choroidal cleft which is situated underneath a contractile fibrous tissue complex and multilayering of the RPE. So this is my patient.
Can you wind up?
Yes, ma'am. Just 10 seconds more. So this is my case of multilayered PED with prechoroidal cleft, who usually does not present with retinal fluid, but after injection, since he is one-eyed, the choroidal cleft changes. So intrachoroidal cavitation, this is a large cavitation in the peripapillary area. It can be associated with sinkholes, which can even be macular in location, depending, and there can be herniation of retinal tissue. So this is a leptochoroid where the peripheral, mid-peripheral choroid is very thin, and there is an area of hyperpigmentation at the macula corresponding to normal choroid. It is not necessarily in myopes. We should know leptochoroid because we have to differentiate it from entities like tilted disc syndrome. This is my case of leptochoroid but associated with dome-shaped maculopathy and tilted disc. So these are not just fancy acronyms. They are good reasons. There are good reasons why we need to learn about them. Helps in treatment and taking decisions of not treating, prognostication and knowledge sharing, and furthers understanding of disease process and progression. Sorry for taking
Thank you,
1-2 more
Apurva,
minutes.
for introducing us to a lot of new acronyms and also telling us that it's useful. Maybe we can have a quick question if somebody has to ask Apurva something while the next speaker gets the. Yeah, Bhavik. Oh, yeah, he's giving you a mic. Yes.
Can you just explain to the audience what you mean by multi-layered PED? Because see, it's saying is easier. You're going to explain?
Yes,
Yeah.
that's his topic.
Maybe I'll just ask you a quick question. Since we say leptochoroid is not associated with myopia, have you ruled out occult myopia? Because very often we see patients, we think they are myopic, their refraction is low myopia, but actually they have a long axial length. So does leptochoroid fit into that category?
Yes, ma'am. I think if we do an axial length at that area, maybe it is staphylomatous and we have to rule it out. So,
Probably also a keratometry, because many of them have flat corneas which adjusts for the increase in axial length. So
okay, okay.
before making that diagnosis,
Right.
again, keratometry. And yeah, Ramesh, you wanted to? That's okay? Okay. So we now have Dr. Mohit Dogra, who's going to talk to us about acronyms in AMD and their clinical significance.
Thank you, ma'am. Thank you for the intro, and thank you to Divyansh in absentia for this opportunity. Because the time is short, and initially we were told that this is going to be an hour and 30 minutes, but it was truncated to 55 minutes. I'm just going to be talking about two entities and hopefully talk about them in detail. One is a multi-layered PED, and the other is FIPED. So it's just those two, because otherwise I can't cram things in in that time. So multi-layered PED. Just going to start with the case and then hopefully kind of compress the findings together at the end. So 47-year-old male presented with sudden onset of metamorphopsia in the left eye since 5 days and a gradual decline in both eye vision since 2 months, since August 17, long time back. That's the right eye, that's the left eye, typical you know uh, vascularized PED, both the eyes. There is a prechoroidal cleft, as you can see. I don't know whether there as well, and there's fluid, sub and intraretinal, in both the eyes. Both the eyes were treated. The right eye, unfortunately, after a couple of ranibizumab monthly injections, the patient was scheduled to receive the third one, but just 10 days prior to having received, sorry, having been scheduled for the third injection, actually ripped, and the acuity actually dropped a bit, and you can see the rip there, and that was unfortunate. The left eye was being treated as you would regularly. The right eye also then subsequently went on to develop a massive submacular hemorrhage. I could not retrieve the Optos ultra wide field, but trust me, it was extending to the aura in two quadrants and up to the equator in the other two. Uh, and we did try and suggest surgery to the patient, so, and weighing the pros and the cons, the patient refused any intervention in the right eye. So now essentially a monoocular patient. We suggested at that point in time that we should be switching from ranibizumab to aflibercept, since despite 2 monthly ranibizumab injections, the right eye had gone down the route that it did, and that's what we did. The patient continued to receive once being shifted on aflibercept injections. June 18, you can see the change in morphology. You can also see the change in morphology of the PED from the outset. You can now see that instead of the at the outset, when you had those vertical lines, you now have these hyper reflective and hyporeflective alternate kind of lines which are going all through, which kind of also mirrors the clinical appearance. It was more orange to look at when it was treatment naive. It's now a little more orangish yellow, and you can see that patient was fairly well controlled on aflibercept, ended up needing about 3 aflibercept injections a year. The octa is showing that complex at the base. This is 5 years follow up, and now it's your typical garden variety multi-layered PED, which is tight, which is compact, which is lot alternate hyper and hyporeflective vertical lines which are parallel to the retinal pigment epithelium may or may not be associated with the prechoroidal cleft. It was at the outset when it began, but with treatment, these can tend to collapse as it did. And some people have looked at a prechoroidal cleft maybe being indication for treatment and also having some prognostic significance. So just to quickly sum up multi-layered PD, a relatively recently established labeled entity, it generally signifies a more stable clinical course down the line. And generally, the visual acuity can be fairly well preserved at the level that the multi-layered PED patient presents with SRF. It also indicates a couple of good prognostic signs, as in once you get the multi-layering, the chances of a RPE rip or a massive submacular hemorrhage, both of which unfortunately happened in the fellow eye of this patient, are considerably lower. And typically, so this patient got the multi-layering after 2 ranibizumab and 6 aflibercept injections. So it also, if a patient just walks into you also know if a patient has a multi-layered PED, although you could get this de novo, but it's much more commoner to get this down the line once the patient has been chronically treated with anti-VEGF. So that is your multi-layered PED. Coming to FIPED, which is flat irregular pigment epithelial detachments. I don't know how much time I have. We'll see. So flat, I think it's self-explanatory what it means. Flat, it's irregular, it's a pigment epithelial detachment. So flat means it has to be low, and so the height less than 100 microns, at the max anywhere, and at least 500 microns going, in the extent. So it could be 500, 1000, 1500, but it has to be at least 500 microns the extent that way. And because it's flat, it has to be low, so not more than 100 microns, right? It could be vascular, it could be avascular. I'm just going to show you quickly both examples, time permitting, and see how both of them differ and whatever similar. And because this is AMD, I'm just talking about FIPED in AMD and not CSC and other things. Again, elderly males had sudden loss of vision secondary to AMD. The left eye, that's an artifact. I apologize. That's also the same blown up image. You can see multiple drusions. Clinically looked okay. That's the radial OCT going all through, and you can see there's no sub or intraretinal fluid. However, you can see these, right? You're almost, so that is so the multiple pigment epithelial detachments, they aren't high, but they're kind of spread all over. It's like almost like spilling a glass of water on the floor. It'll actually flow and be a lot much more in horizontal extent than vertical extent. One-eyed patient, the other eye had that. I'm going to finish in half a minute. This patient had a nascent, MNV, sitting right beneath the the RP, and you can see it was co-localizing to that area. What happened to this patient, I'm not talking about, but that is one thing that you can, a vascular FIPED can point to that. The other, which is the avascular, again, this patient had shallow irregular pigment epithelial detachments all there. I just want you to concentrate on the right eye. Was asymptomatic all throughout, but had this shallow drape of subretinal fluid beginning in 2016. Imaging, both fluorescein, ICG, as well as OCTA showed no membrane, no evidence of any activity. And again, please just concentrate on the right eye for this. This is 1 year follow-up. That shallow drape of fluid remained the same. The FIPED actually elongated horizontally a bit, but again was observed. Again, this is 2 years down the line. The SRF is persisting. This is again 3 years down the line. Repeat FAICG, OCTA not showing anything. The SRF is persisting. The acuity is maintained. Patient was lost to follow-up 2.5 years due to the COVID pandemic. Came back, a total follow-up of 6 years. October 2022. The angio was repeated. You can see that although the the drusions have become a little more confluent, there is the acuity is maintained. There's a sliver of SRF. So what I basically want to say is that avascular FIPED can still have some fluid, and that is one of the cases in which you might have what we now know as what looks to be exudation but is non-neovascular. So if you have if you have FIPED, it is avascular, clinical exam, and on OCT and on OCTA, and you can't demonstrate a membrane. The subretinal fluid is there. It will remain like that for a long time. and does not need treatment, needs observation. I wouldn't even say close observation. I'd say 3 to 4 monthly apart observation, as this case showed that 6 months for 6 years follow up remain the same. The acuity is the same. So vascular rule out type 1 MNV, avascular rule out. I mean, you should try and keep in mind non-exudative AMD. Thank you.
Thank you, Mohit.
Sorry, again overshot.
I probably just would have one comment that a lot of the pictures that you showed looked very typical of a neovascular network in PCV and confluence of drusen in AMD. I think typically we reserve FIPED for the entity associated with CSCR when we see that little ripple and we're not sure is there neovascularization or not. So probably, maybe since this is acronyms, we would probably ignore the ones where you have these confluent drusen where everything is homogeneous, and I think at that point we are not really worried about whether it's neovascularization or not.
Fair enough. I totally agree, but because I was put in the AMD group, acronyms in the AMD, I wanted to try and showcase which are those.
Yeah,
And that's
but
why at the
they're
outset I
very
said I'm not
nice,
talking about CSC, ma'am. But fair enough. Absolutely.
Very nice
Absolutely agree.
cases. Thank you. Does while Bhavik gets his talk up, anyone has a comment or a question? Yes, Shane.
Drusenoid exudative detachment. That's a new entity which we have all been talking about.
Yes.
Can you explain a little further on it? I'm still not clear on the idea. Is it is it an extensive form of drusenoid PED which we are talking about earlier, or is it like a flat drusenoid PED with a little SRF above it as what you showed?
So the SRF will generally not be there.
So I just want.
I think you're talking about the cap of fluid on top of a
absolutely.
PD.
So there's
yes.
an entity which is being recently described as a drusenoid exudative detachment of the macula.
Yeah. So that's so
I'm just trying to.
Yeah. So that is exudative non-neovascular AMD, in which you have exudation seen on the cross-sectional OCT, but it'll not be intraretinal fluid. It'll be subretinal fluid, and you can get it in 3 kind of different scenarios. So one is if you have a large tense PED, like you can get it, at the top, like a cap on top. You can also get what might appear like SRF at at the junction where that large blister joins the retina because of a geographical effect. So the edges, the top, and the third is the one that I showed, in which you have flat irregular PEDs, low lying PEDs, and you have a shallow drape of SRF over it.
All these are called exudative drusenoid.
Well, no, well, they aren't called anything, but that's what the paper and that's what Dr. Bailey's work and actually labels them as, because I think it's the easiest to understand that way. They're exudative because you see exudation on OCT, but they are non-neovascular because if you do FA, ICG, and or OCTA, you are not able to demonstrate a membrane. So it's non-neovascular, but there is exudation. So it's not related. So it's not
in the form of subretinal fluid.
Yes, in the form of subretinal fluid. If you see intraretinal fluid, then it's not this, because then it's
exudates beneath the fovea. That's not what we are looking at.
So not exudation as in diabetic retinopathy. Exudation as in the form of a subretinal fluid seen on cross-sectional OCT.
So something similar to what you just showed.
Yes.
Thank you.
I'll show you some pictures if you attend the next Unni's session.
Oh, okay, I'm definitely there.
Yes,
Yes.
Bhavik is going to talk to us on acronyms in OCTA.
Yes, good morning to all the listeners here. So I'm going to run across, not run rather, I'm going to take you a few acronyms and stick to my timing as well. So just an example here, this is how an OCT angio looks like, and where the first 2 slabs are the inner retina, superficial inner retina, and the deep inner retina. You have the outer retina and the choriocapillary complex, okay, in the B scan, and the combined composite angiography image here. So what I'm going to describe today or explain in short is about the 4 entities out of the 8 given to me because of time constraint. Cut it down to 4 is DSM. So DSM stands for dome shaped maculopathy. Something was labeled as SHRM and SHE. SHRM is subretinal hyperreflective material and SHE is subretinal hyperreflective exudate. They both are not interchangeable. SHE is a subset of SHRM that we'll come across. non-exudative CNV and type 3 CNV. Octa was given to me as a topic. We'll start with DSM. So, dome shaped maculopathy is characterized by a forward convex, okay, bulge of the macula that is observed in the hyalomyopic eyes, okay, especially in the OCT. And you have to understand that you need to go to the vertical scans of this OCT. If you look at the horizontal scan, you may not be able to capture it, but a vertical scan will be able to get this forward complex bulge, which you'll be able to see. Same thing if you see here, the horizontal scans in one of the patient here does not reveal the bulge. However, there is presence of a CNV in one of the patients here and with the bulge. So DSM or dome shaped maculopathy can be associated with subretinal fluid. It may or may not be related to CNV, right? So one way of identifying this is the presence of octa. Octa, in especially in the outer retinal slab, will help us identify whether presence of CNV is there, and the fluid is because of the CNV. So development of CNV is independent of the presence of DSM. It is associated with increasing age, higher axial length, and thinning of the choroid. And this octa here helps detect CNV in the outer retinal slab. Going to the next subset, that is SHRM and SHE. So basically SHRM includes a subset of, that is type 2 neovascularization, as we saw in the previous presentations as well. Most of the presentations had the SHRM component. It can be either subretinal fibrosis, subretinal hyperreflective exudate, acquired vitelliform lesions, or presence of just a subretinal hemorrhage. They all can be classified as SHRM. Okay, so just examples of the same here. Angiography here, OCT angio helps us identify what subset it is based on, say, intrinsic vascularity, reflection of the from the retina to the SHRM level or to the RP level. And with this, we can understand whether we are dealing with a subretinal fibrosis or dealing with a neovascular component or a subretinal hyperreflective exudative material. Okay, so this is the artifacts of the OCTA, helps us identify and distinguish between the different components of SHRM. Third component here is a non-exudative CNV. This here, the importance is that it is mostly seen in the fellow eyes of patients who already have AMD in the or exudative CNV in the other eye, right? So these lesions, if identified at an earlier time, we know we can treat them better and a better prognosis for the patients can be achieved. Just one case here, patient present 2018, had a PD but no exudation, vision was good, and no net which was noted on the octa. Maybe a small net was noted when you see retrospectively. Going down a year later came a diminution of vision, and we see here a small net which was there. I'm not going to details of the treatment part of the patient, and this net has enlarged over a period of time. The last component here is a type 3 CNV, that is the RAP lesion. Here, basically, clinically, it's a diagnosis where you have few hemorrhages which are seen, and this tiny intraretinal subretinal hemorrhages correlate to the OCT angio in the deep deep inner retinal layer. Okay, so the net present in the deep inner retinal layer reflects or explains us towards a diagnosis of a RAP lesion. Just last two slides in understanding when do you call CNV as active using octa. When there is tangle of vessels in a well-defined shape, the classical Lassie wheel pattern seen on angio. There is anastomosis or looping of the branching of the numerous tiny capillaries. Presence of a hypointense halo. Okay, again a very important sign, and that halo, once it regresses, can also suggest that activity has gone down. So larger, more mature vessels, dead-tree appearance, and no perilesional halo points us towards an inactivity on the OCT angio for a CNV. Just the take-home message quickly: dome-shaped maculopathy helps differentiate the fluid which is present in OCT angio helps differentiate the fluid present in dome-shaped maculopathy, whether it's related to CNV or not. SHRM, various types can be identified through the various artifacts on the OCT angio. Non-exudative CNV, octa helps us to identify it early, diagnose early, and had a better response. And type 3 CNV or the RAP lesion, that is seen in the deep inner retinal slab. Thank you so much.
Thank you, Bhavin. Most importantly, for such a nice, crisp presentation, keeping to time. We have a time for one quick question. Anyone has a question? Ramesh can start getting.
Thank you.
One question that till the time they swap the laptop, so what would be your treatment plan for a non-vascularized shrimp? You can start.
So a non-vascular stem, whether it's a fibrosis, is important to identify whether it's a fibrosis or it is an exudate or a vitelliform lesion there, or it can be hemorrhages, right? Clinical, this is based on the OCT, but the clinical scenario also matters, and the past history of the patient, like what Dr. Mohit showed. If you have multiple injections taken and it's
So
a
sometimes
fibrotic
it can
component,
be like there can be a regress
it
seen.
either
So
it can
follow
be
it up
observed
closely,
or true.
and Octa may help. Thanks. Good morning, all, and sorry for being extremely late. And again, very sorry.
I now request next speaker Ramesh Venkatesh to speak to us on surgical related acronyms in imaging.
At the outset, thanks Divyansh for this opportunity, and let's start very fast. Okay, I've been asked to talk about 4 acronyms, so I'll start with the first one, which is basically related to the macular holes and the macular hole surgeries. So the first one is going to be on the lamellar hole LHEP, which we commonly call them macular hole factors, the SANFL and the DONFL. So LHEP is basically the lamellar hole epithelial proliferation. So it's basically, you can see with the arrow that there is a homogeneous mass of medium reflectivity which is lying over the retinal surface. So in a patient with lamellar macular hole, you have a mass-like tissue which is present at the edge of the lamellar hole, which is homogeneous and medium reflectivity. And what causes the LHP is basically, there have been multiple theories which have been put forth. One of them being the migration of the retinal Muller cells to the epiretinal surface, and in some cases there is migration of the retinal pigment epithelial cells as well. And with this photograph, you can see that there is an LHEP, but what you can also see in the central part is there is a discontinuity of the ellipsoid zone or the ISOS junction. So LHEP basically is associated with poor baseline visual acuities. They have larger macular hole diameters, they have a very thin residual retinal tissue, and there is an higher rate of inner segment, outer segment band disruption. What is the clinical relevance? Now, patients without LHEP, they usually tend to present with a good visual acuity, and therefore they do not have any disruption of the outer retinal layers, and therefore because these patients have a very good baseline visual acuity, most of the retinal surgeons or the patients who present with lamellar macular holes, the retinal surgeons tend to avoid or defer surgery in these cases. However, in LHEP cases, there is usually an outer retinal layer disruption, and there is a reduced visual acuity, and therefore the visual acuity outcomes even after the surgery, they tend to be not very good. So LHEP, or the epithelial proliferation, is not only seen only in lamellar macular holes. So the term LHEP, the lamellar macular holes, is not the right way to describe it. It can happen even in cases with full thickness macular holes. With this photograph, you can very clearly see the epithelial proliferation happening at the edge of the full thickness macular hole. Even in this photograph, you can see that there is this, and therefore the term LHEP is now being changed to what is called as the EMPF, or what is known as the epimacular proliferation, which you see. And there is a surgical relevance to cases where you have LHEP or epimacular proliferation. The peeling of the proliferative tissue is important because it can lead to recurrences of ERM formation if not removed completely. And aggressive peeling in a case of epimacular proliferation in a lamellar macular hole may lead to a conversion from an LMH to a full thickness macular hole, and care should be taken not to forcefully pull it, and applying a minimal traction may theoretically reduce the possibility of the retinal tissue or the formation of a full thickness macular hole. So this is our publication where we spoke about the epimacular proliferations in patients with lamellar macular holes, and this is something which we can have a read later on. Now let's look at the macular hole factors. We know the 4 important factors which are important in preoperative decision making is the hole forming factor, the hole index, the macular hole index, the diameter hole index, and the tractional hole index. I'm not going to stick to these indexes, but I'm going to talk about something which is beyond it. So this is what is called as the MAI, is known as the macular hole area index. The MTAI is called as the tissue area index. The CSAI is called as the cystoid space area index, and this is something which we calculated using the IMAGE algorithm, where we had the full thickness macular hole, from which then we create a trapezoid area. That is the area which is going to be considered as the total area of the involving the on the OCT. So the C is the entire thing, and then the C, you can see that there is a dotted line which is shown, which is actually calculating the area within the macular hole itself. then you subtract that area, what you're left, you do a binarization, then you have the cystoid spaces and the tissue spaces. The tissue spaces are being shown as hyper or white in color, whereas the cystoid spaces are black in color, and that is how you calculate the cystoid space area and the tissue area index as well. How is it important? Because large macular hole area, when you have a very large macular hole, they are associated with failed macular hole closures. And when we say type 2, basically we indicate that they are not the typical macular hole closures which we expect. And you can see that the area under the curve for the macular hole area index is much high. So this is again our publication where we spoke about these indices which help in predicting the macular hole closures for idiopathic macular hole. Let's look at the next entity, which is the SAN-FL. The SAN-FL is basically a swelling of the arcuate nerve fiber layers, and what it tells you that it is occurring after the internal limiting membrane peeling in an acute immediate postoperative state. So let me show you a photograph of a full thickness macular hole preoperatively, and this is after 8 days post the macular hole surgery, where you can see these radiating lines coming from the edge of the disc. And what you can see on the OCT, when you pass an OCT scan through that area, you can see there is a focal thickening of the nerve fiber layer. So this SAN-FL, it actually regresses or resolves over a period of time. These are multicolor images of the same patient where you can see these radiating lines which are happening immediately post-operatively, and over a period of time they start resolving itself. These are the OCT photographs which you can see that the SAN-FL keeps decreasing over a period of time. So it happens in the immediate postoperative period. It is the swelling of the nerve fiber layer when along the arcuate nerve fibers. It is a transient phenomena. It resolves spontaneously and does not affect the visual acuity. Let's go to the last entity, which is the DON-FL. It was initially called as the dissociated optic nerve fiber layer, and it was Spade who actually clarified this and said that there is nothing affecting the optic nerve. It has nothing to do with the optic nerve fiber layers, but it is just the inner retinal dimplings which you get. And these patients, so this is a case which I wanted, this is the OCT of the previous case itself, where you can see these inner retinal dimplings which are seen on the OCT scan. And this morphological evaluation, this paper, it actually says that this can happen over a period of time after the macular hole surgery, not something like the SAN-FL where it happens immediately, but it can happen over a period of time over the first 12 months following the ILM peeling. Let me show you these photographs of my cases where you have, this is the preoperative photograph. Following the closure, following the surgery, you can see the SAN-FL developing, but the macular hole unfortunately did not close. Then we redid the surgery where we gave further gas injection and prone position, and now you can see the SAN-FL is totally reducing. But what you can see at the end, this is almost a year later, you can see these multiple spots which are seen in the, or depressions which are seen on the fundus examination. This is much well seen on the blue reflectance and the green reflectance imaging, where you can see these hyporeflectance spaces which are seen. And when you do the OCT or the on-fast OCT in these spaces, you can see these depressions or defects which are seen, which are suggestive of the inner retinal dimplings, which are also seen on the OCT B scan along with it. So DON-FL occurs in the area of ILM peeling. They are inner retinal dimples. It's a misnomer and nothing to do with the dissociation of the optic nerve fiber. It is not seen in the immediate postoperative period and does not have any effect on the visual acuity. So to summarize, LHEP is same as epimacular proliferations, and they indicate poor prognosis. Macular area index, it indicates a poor closure. Larger macular area index indicates poor closure. SAN-FL, it's seen in the immediate postoperative period, and it's a transient swelling of the arcuate nerve fiber layer, while DON-FL is not seen immediately, and they are inner retinal dimples. Thank you so much.
Thank you very much, Ramesh. Beautiful photographs, and it's nice to know that what we do doesn't affect the visual acuity, though probably later when we do secondary visual functions, we'll feel different. Just want one quick question while Pradeep is getting his cases ready. Anyone from the audience? Otherwise, I'll ask him one. What does LHEP or epimacular proliferation look like when you're operating? How do you identify it clinically?
So
because there are many times we think that's what we are seeing.
So it looks like a dull yellowish orangish tissue which is seen at the edge of the macular hole, ma'am, actually, and it's a very tough tissue. So when you're trying to peel up the ILM, it at the edge of the macular hole, there is a tissue which doesn't actually come as easily as when you try to peel the ILM tissue. So it looks like a homogeneous yellowish dull yellowish tissue which is present.
Yeah, and doesn't stain well also.
Doesn't
Your
stain well,
thing
that's right.
doesn't stain well. You have that little rim which doesn't
It's
stain.
basically
That's
on the
flow.
epiretinal membrane. It's on the epiretinal surface. So that's
Yeah.
it.
Thank you so much.
Can I add something? So the LHEP, as what we are discussing, we have to take a call that whether to operate or not to operate, because it's very densely adherent to the centermost fovea or the fovula. Because if we try to peel that area, we may cause more injury rather than having any positive effect to it. So better is to just peel to the end of the macular hole and then leave it. Yeah. Pradeep, thanks.
Yeah. At the outset, I would like to thank Dr. Divyansh and ma'am for giving me this opportunity. So I will be discussing a few acronyms. So I will be discussing each cases. Like is the case 1, a 58-year-old gentleman presented with 618 vision in the left eye, and he had proliferative diabetic retinopathy. We can see on OCT there is no macular edema. The outer retina is normal, but what we can see is in this half, that the nasal half, we see that the individual layers of the retina can be differentiated from each other. But whereas in this temporal half, we can't make out the different layers like from each other. We can't make out that there are different layers. It appears more often homogeneous one. So this is termed as drill or disorganization of retinal inner layers. So why we need to know this? Because as we can see over here in this case, we can see that the temporal half shows areas of ischemia. So there are a few publications which even have noted that correspond to the area of macular ischemia. So how it can help us is it's a surrogate marker of macular ischemia. So those who don't have an OCTA or don't want to do an FFA in a case, macular ischemia can be, it's not definitely a macular ischemia which we can identify an OCT itself, but drill shows that it is probably an area of macular ischemia. So it's a surrogate marker that explains the poor vision in this case, which is 618. So moving on to another case, in this case it was a stable PDR following PRP with center involving DME. Here we can see that this part we can make out the layers differently, but in this half, the supratemporal half, what we are seeing here doesn't show that different layers as distinct layers actually. So post treatment, we could see that there was a good resolution of macular edema, but the vision didn't improve much. So again, drill is an indicator of functional outcome, a poor functional outcome. In this case, there is an additional component of outer retinal loss also, which can be even contributing. So again, what we need to understand is like it's a biomarker of poor functional outcome. So moving on to another case, a 58-year-old gentleman presented with a central retinal vein occlusion with a cilioretinal artery occlusion in his left eye. So he was one-eyed. At that time, we could see that there is area of retinal whitening which is corresponding to the area of cilioretinal artery occlusion, but even in other areas we could see that there is a hyperreflective band at the level of outer plexiform layer. So this hyperreflective band is termed as the prominent middle limiting membrane. So why we need to know this? So this case in future developed recurrent edema over a period of 16 months, received 12 anti-VEGF injections, also developed a rubeosis iridis after 12 months, and he was treated with PRP and he still continued on anti-VEGF therapy. So the prominent middle limiting membrane indicates that it's ischemia. The patient presented with a relatively good vision and not much of an edema at the beginning, but we could see that prominent middle limiting membrane in the entire macula, which may be an indicator that there was a significant ischemia to this case. So moving on to another case, a 61-year-old lady with a moderate non-proliferative diabetic retinopathy with DME with a vision of 6/60. So like here we can see that at the fovea there was a cystoid space with hyperreflective material lining the inner wall of the cyst. So this is termed a pearl necklace sign. This is not an acronym. This is the only entity which is not an acronym in this presentation. But Dr. Divyansh asked me to include this, so I have included it. So like post injection, like with triamcinolone in this case, like we could see that there is precipitation and aggregation of this hard exudates at the center. So like and the patient actually maintained a vision of 660, did not show any reduction in vision, but it has been reported that like presence of pearl necklace sign can be considered as a marker for a risk of hard exudate precipitation and vision loss following therapy. There are a few cases like small series in which they have noted that those with pearl necklace sign have developed vision loss due to precipitation and aggregation of hard exudate at the center of fovea following injection. Moving on to another case, a 54-year-old gentleman with moderate non-proliferative diabetic retinopathy with DME. On OCT, we could see that there was neurosensory detachment at fovea with macular edema, and we can see that there was hyperreflective rim with a hyporeflective lumen, which corresponded to aneurysm with the white rim. So what is it like? It has been termed as a retinal cap. There are various terminologies which are used to describe this. So a similar looking entity has been described as retinal capillary macroaneurysm by a few authors, telangiectatic capillaries by a few authors, and in idiopathic conditions has PVAC, peripheral exudative vascular anomalous, perifoveal exudative vascular anomalous complex. They are not really significantly different from each other. Most have a similar clinical characteristics. So in this case, the patient didn't respond well to bevacizumab. Like we gave bevacizumab 3 doses, he didn't respond well. Then we treated the lesion with laser photocoagulation, and we can see that there was a complete resolution of macular edema, and that entire area was replaced by homogeneous hyperreflectivity, and there was no recurrence till 6 months follow up. So what we need to know is like they can be identified on clinical examination and can be confirmed on OCT. They are a biomarkers of poor response to anti-VEGF therapy and reasonably good response to steroids and very good response to laser. Case number 6, a 42-year-old gentleman with myopic choroidal neovascularization. What we can see is there is subretinal fluid. At the same time, there is split in outer fiber of photoreceptor cell. So this is called the bacillary layer detachment. So bacillary layer is basically the inner and outer segment of photoreceptor. That's termed the bacillary layer detachment. And when there is a split in between them, then it's called a bacillary layer detachment. So it can be seen in a lot of conditions, like as it is mentioned over here, but as of now we don't know like whether it has any clinical implication. Thank you.
Thank you very much, Pradeep. I think very nice demonstration. I think we have to just rush. Divyansh will now give his presentation on the acronyms in MACTEL. I think Pradeep, your case explained everything perfect. Anyone can ask him a question while he's sitting here.
So, good morning, all, and thank you for being here on a Sunday morning, 8 o'clock. And I'm regretful that I was the last person to be in my IC as an instructor. Again, highly regretful. Carrying with the topic. So, the topic for me, which I had selected, was the clinical implications of acronyms in MACTEL, which type 2. So what I would be covering is invasion of a vascular layer, which can be either proliferative, non-proliferative, or SRNVM, and an intraretinal NV, that is intraretinal neovascularization, or an ERNVM, the coined term by Dr. Apurva and Ita. So the avascular layer is the layer in the outer retina, or sometimes we can have another segmentation, which is ORCC, that is the outer retina choriocapillary slab. Because usually we would see that there is no vascular signal in that. And if we are finding anything in that segmentation, that means there is invasion of that avascular layer. Either it can be of different variations. So in cases of MACTEL, as we can see, there is the whole temporally there can be intraretinal, or either it can be a neovascularization complex itself, which we can see in those areas. And as in this case, the FFA is also showing leakage. And this is the pre and post after the treatment when it completely regresses also. So most importantly, Octa helps us to identify those lesions and also try to follow it up those lesions, whatever are there. So this is the same case with the other eye. What we can see, the lesion in the right eye remains to be the same and does not increase. This is a follow-up over 3 months, as what we can see. Other possibility of invasion is the small PEDs, which has a good flow signal, as what we can see. And we can see that in the outer retinal layer, there is a very small network. And if we follow up such cases, because at this point of time, there is no particular indication to inject. So following it up after till 18 months, as what we can see, gradually those areas of PED or that neovascular complex is increasing. So this is a comparative image for the same patient, as we can see after 18 months, that there are different or the completely different areas. As you can see, there is a separation of that small PED from one side to the another. So it started from here, and there is here at this point there is nothing, and then again there is a small PED. So this is the same image showing that it is completely different lesion, or the same lesion which is sub RP and then later on showing up. Sometimes whether we feel whether these are the segmentation artifacts, but if we do an octa and look for the B scan signals, as we can see, it shows high signal intensities in those cases. As we can see, whether this is artifact because it's showing some flow within itself. So what to do for these cases? It's just to keep following it up. And the similar cases, this case was very particular. As we can see, those hyperreflective small dots which we are seeing in the or the flow signals which we are seeing in the outer retina. This, when we compare on the follow-up, there can be a little increase. So this was the case where we followed them up, and then we could see that. Okay, I'm sorry. This would be the case. Yeah. Oh. Yeah. So whether there is actually an increase, because as what we can see, those small hyperreflect or flow signals which we are seeing in the outer retina, those are looking to be increasing, but whether actually there is a neovascular complex, we do not know about that. So these can be segmentation artifacts in Mectel, what we can see. And this is a case where we can see that there can be intraretinal neovascularization, which is seen in the superficial slab. And we can have epiretinal neovascularization also with intraretinal neovascularization. So in this case, we can see that this is the VRI slab where we can see the neovascularization is on the retinal layers, and this is intraretinal. And there can be associated traction sometimes. These are the cases where this patient was having proliferative diabetic retinopathy. So we are not sure whether the neovascularization is primarily because of the diabetic retinopathy at the fovea, or probably with the this we had published before. So thank you, and we would be open for discussion.
Thank you, Divyansh, for that nice presentation. Probably we have time for one question before we give the hall on time. Anyone has a question or a comment? Yes, sir.
With respect to Pradeep's talk, I just want one clarification. Whether drill is something that is to be assessed at the time when there is acute edema, or after the subsidence of edema with pharmacotherapy. Because what appears like drill in the acute stage will actually not be so when it is gone.
We can assess drill best when the edema is completely resolved or is come down. Like in edematous eye, like it may be difficult, but if the edema is localized to the outer nuclear layer, then the inner retina can be still very well seen, and we can make out drill. But if the edema is involving even the inner retina, then probably those are the cases in which we may overestimate drill in cases with edema.
So at what point of time is it a surrogate of ischemia?
So this is something like whether when a macular ischemia like when the capillaries start occluding, maybe definitely we can expect that there may be still a normal inner retinal layer, but once that ischemia has already developed, and over time those areas will definitely lose their organization, so they will become disorganized.
Probably,
This, to answer this, probably we need further studies.
Yeah, maybe what I would say is if it is gross edema, then maybe you cannot diagnose drill, and you definitely would not treat the patient. But if there is questionable edema and poor vision and you see drill, then you may think twice. So I think when there's a very thick, say 700 microns, and you think you can't see the layers, I think then we would go ahead. So in that situation, it would be more of retrospect.
So thank you all, and thank you Apurva, Mohit, Bhavik, and Ramesh, Pradeep for helping us conduct the IC with all the acronyms, and thankful Munna madam to be with us early in the morning, and again I'm regretful for being late. Sorry. Thank you.
Thank you all for coming.